Hillsman, a postdoctoral resident and a graduate of our doctoral psychology program. We're excited about the project that you all are involved in. I want to talk with you a little bit about some of our experiences and some thoughts we have about helping people who have been traumatized. And I was mentioning over here to Alex and Allie, and I almost am sorry I have to share this, but I've personally responded to 15 school shootings over a period of about 30 years, including responding to Stoneman Douglas. But I remember years ago, secretary rushes in and says, there's been a shooting at Langham Creek High School. You know what my first thought was, to tell you the truth? How could that have happened? We just opened that school building. It cost about $40 million. So I was really high on denial. Then she said, Marvin Webster, the assistant principal, was shot. Now you can forget the denial. Now I'm angry because I happen to know Mr. Webster. And by the way, he did recover. And it was a 15-year-old kid who shot him. And Marvin will walk with a cane for the rest of his life because the bullet hit his spinal cord. Then they said, they want you right away. In all honesty, forget the denial and the anger, enter panic and anxiety. I remember getting in the car and having to give myself a little pep talk, like, I can do this. I've had some training. I had to say things as basic as, turn the wheel to the right because the school is that way. I'll be calm and I will be collaborative. By the way, for the most part, the day of the tragedy, you know what everybody really wants to do? They just want to go home. They want to be with their loved one. So most of our psychological interventions of any length or that are complicated at all, those would be on day 2, day 3, day 4, day 5, after everybody got reunited with their loved ones and hopefully they got some sleep. And then maybe the next day is when we might actually talk to them. But that's almost the wrong words because it's not that we really talk to them. Our role is primarily to listen. For one of the presentations we did recently in our college, as we were approaching the 2nd anniversary of Stoneman Douglas, I interviewed one of our former graduates who has a really important job. She's the director of terrorism and natural disasters for the children. National Center for Children, Trauma, and Stress. And so I was asking Dr. Brimmer, we both asked her in an interview, what do our graduate students in particular in psychology, what do they need to know more about? And it was all about grief, being able to help others with their grief. And then she also stressed listening. Sometimes it's simply just being there next to the other person with gentle statements like, I'm here to listen if you would like to talk. So we need to be careful not to talk too much. One more example. So there was a shooting in one of the schools where I used to work in Houston, Texas. Students were fired on several other locations. But I want to tell you something, be very honest. You know what my first thought was? What about my kid? My kid is in the 1st grade. My kid goes to one of the schools where shots were fired. See, sometimes it's really difficult to think about the needs of anybody else until you know your loved ones are secure. It's all about what can we do to at least increase a little more of a thought of safety, security, and belonging. So Dr. Hillsman and I both work in the Suicide and Violence Prevention Office, and J.R. Sosa is one of our graduate students who volunteers in that office. We have a lot of resources. We'll hope you'll check them out. We've done a lot of interviews with people that are well known in the field, including Dr. Brimmer that I just mentioned. Okay, now, a few slides. Maybe? Here we go. So, possible scenario. We're not exactly sure what scenario you'll be faced with, but this is a sample in terms of People have been injured. There's been a shooting on a school campus. Now that I've mentioned that, though, I need to tell you something. The media has given you all the impression that schools are unsafe places where shooting is likely to occur. And in reality, it's like every college or every middle school or high school, they could expect somebody shot about once every 3,000 plus years. And having said that, one shooting on a campus anywhere in America is unacceptable. But by the way, the majority of those incidents where somebody gets shot on a campus, it's an accidental discharge of a gun, or it's somebody who died by suicide. Thankfully, these mass shootings are very, very rare. So, questions, and we're going to be giving you some ideas today in terms of how to possibly respond. And I've already mentioned a couple of things that I think are important to repeat. Realizing people want to be reconnected, reunited with their loved ones. They don't really want to be peppered with a lot of questions. It's more about being next to them. I care. If you want to talk, I will certainly listen. So there are what are called the circles of vulnerability. And these circles of vulnerability, I learned from some psychologists in Israel some years ago. And three main dimensions. And I want to put this in the context of, sadly, something that happens pretty often. That would be a car accident. So imagine Tom was in the car, his best friend Bill was driving, Bill was killed, Tom survives. And what if I tell you Tom's mother is dying of cancer right now? Think of this as like a psychological triage. I gave you geographic proximity. He was right in the car. I told you his best friend was killed. Psychosocial proximity. And then every single one of you, everybody you will ever interact with, it's like we all have our own trauma history. And when bad things happen, just know it's very common to think about our losses. So to be a little more specific with that geographic proximity, it would be who was right there. I gave the example of Tom was right there. Well, maybe some of their best friends were following in another car because they were all on the way to a concert. Or maybe other people were in a neighborhood, but they heard police sirens. So they had at least some exposure, and maybe somebody else wasn't involved. They were out of town that day, visiting a college, for example. So if we go to the psychosocial, immediate family, the absolute closest, anybody here have a twin brother, twin sister? That's the absolute closest. Some of you probably have a same-sex sibling, maybe 1 year older or younger. Many of you would have siblings. Then we're going into close friends. Then we're going to just people that you know from your classes, but they're not your best buddies. And then, you ever heard the term that some people are just like really sensitive? They just identify with everybody's thoughts and emotions. They didn't maybe even necessarily know the victim, but they're just very sensitive to when people have experienced pain and loss. So our third circle is population at risk, because somebody might have lost an older brother or a mom or a dad in a car accident. So they've experienced a loss from a very similar cause. They might have had a family that went through a very significant event last year, the loss of someone in the family. Maybe there was a divorce. Maybe they're in the middle of a breakup with a long-time relationship they're in. So, main point about all of this is, of course, looking for that intersection. So the medical community and personnel, they have a numbering system like who can wait, who can't wait, who, if we can do something right now, they just might survive. Well, this is essentially a psychological triage. Want me to be honest in my work? Very difficult to get schools to think this way. If you think this way, your crisis intervention is not over in a few days or a week. We'd be looking at long-term assistance. And then these same psychologists talked about what they call the 60-20-20 rule. And I think this has some relevance for the activity you're going to be involved in. Think of it this way. No matter how staggering the traumatic event, 60% of us, we're going to be okay. We're going to turn to our existing support systems. In fact, the one question I do like to ask, mostly I'm listening, but at some point I might ask, who or what has helped you before? Who or what can help you now? Who have you turned to when you've had another loss or another traumatic situation? Obviously, we're hoping they come up with things like faith, family, trying to think positively, exercise, getting enough sleep, eating correctly. Here's a simple one, but after a traumatic event, everybody has to gather the next morning. Somebody brings in things for them to eat and drink. Can you think of what they probably bring in that's not going to make things go particularly well? Going to have coffee? Want people who have been traumatized to have extra caffeine? Want to bring in sugary donuts? It's like we should bring in healthy things to help people who've been traumatized and truly be there to listen. So 20% minor problems. Maybe some startle reactions, maybe some problems sleeping through the night, maybe nightmares. And by the way, the most typical reaction for a kid to a traumatic loss is this. They regress academically and behaviorally. They have nightmares, worries, and sleeping problems. And those are in some ways pretty much the case for all of us in terms of after responding to shootings. I've had people say, I keep washing my hands. I just feel like I can't get the blood off. It's like I keep replaying it over and over. What I saw, what I touched, what I smelled, what I tasted. And the main point that we want to get across, you're not alone. Those are not atypical reactions. You are not alone. And I want to be here for you every single step of the way. So major problems. I'm really sorry to tell you that the literature pretty well documents that increased suicides follow school shootings. So I'm always advocating for more suicide prevention, awareness, education. But we especially need it, even things like depression screening at a school where a tragedy like the shooting at Parkland has occurred. So one last thing before I turn it over to Dr. Hilsman. Greg Barnes, you ever read about Greg Barnes? Greg Barnes was a Columbine basketball star. He was popular. He was smart. He was going to get a full ride to North Carolina. But on the first anniversary of the Columbine massacre, he hung himself at home. And I would argue, sadly, he's an example of the 20% with major problems. Part of the message in our society after a traumatic event has largely been, get over it. Okay, the good news, that works pretty well for most of us. Returning to some of the communities where I went initially after school shootings, I would sometimes hear something like this. Even the people closest to me say I should be over this by now. They say, I'm tired of hearing you talk about this. And our message should be getting them help, hopefully getting them involved in ongoing counseling. I get this question all the time, but I'll just quote a Parkland parent. My daughter knew 3 of the victims. I think she needs counseling. But she told me she will not go. Mom and Dad, I don't think that's a decision your 14-year-old daughter should make. How about this? Ask her, would you like to see a male therapist or a female therapist? There's a choice. Do you want me in the waiting room as a parent, or do you want me in the session? There's another choice. But opting out of counseling when you lost 3 close friends. I don't think that is a very good idea. So there you see some of the things that traumatized individuals who don't get enough help are potentially at risk for. Increased drug use, depression, reckless behavior. That's particularly a problem with middle school and high school kids if there's been a traumatic event. So let's go on to the next slide. And I'll do this one, but pretty much I've said several of the things that are up here. And by the way, there's this big word called resiliency, and that's the ability to bounce back. Probably some of you know somebody who experienced a traumatic loss, but they went on with their lives. They were always sad about it. Some of you might know somebody, it's like their life was never the same again. Maybe they didn't reinvest in other relationships. Maybe they did turn to drugs. Maybe they got extremely depressed. But what really is the key to resiliency? Being surrounded by loving and caring family and friends. Being comfortable venting and sharing strong emotions. Being optimistic about the future and utilizing problem-solving skills. Part of our work, besides reuniting them with family, trying to restore that sense of safety and security, help them identify those problem-solving skills that hopefully they have used before. And not everybody who's been exposed to a traumatic event is going to need much in the way of help. Probably for some, they just need to know, where can I go if I do experience some of these problems? And having the opportunity to vent strong emotions is really important. So I'm going to turn it over to Dr. Hillman.
Thank you. So one of the things that I have the privilege to do is to teach basic clinical skills to first-year doctoral students in psychology. And we always come from the perspective that it's our privilege to interact with someone who needs help, right? We always want to do that within the scope of our own competence, not going beyond our training. That would be unethical. And we always want to treat them with the utmost respect, thank you, and professionalism. Okay, so how we carry ourselves when we interact with a patient is going to impact their feeling of safety and comfort, right? And the sense of, somebody being there to restore a sense of safety and normalcy again. So I'd like to talk about just a few little basic skills when it comes down to what would I do? How should I approach someone who may need help after a trauma or a crisis? This is based on the psychological first aid program, which is a training that anybody can do. It takes 6 hours and it's free. And it was developed by Melissa Brimmer, who is an NSU graduate. And I'll show you the contact information for that at the end. But some of the most basic skills that they talk about for immediately trying to meet the needs of some patients would be, first you introduce yourself and your role. That shows respect, right? So people aren't just coming up willy-nilly and trying to engage with people and they don't know who you are, right? So the first thing to do is to approach, introduce yourself. Say your name, say what your role is, and say what you're there to do, right? And then you can find out that person's name and ask, is there anything I can do to help you? Again, we're not there to push interventions onto anyone, right? We're there to respond respectfully as needed. You can offer a tissue or water. They may just decline your help. Not all people will want to talk to anyone or have help from someone. Maybe they've already been helped by someone else, right? Maybe they've been helped by another person and had a bad experience and they may just want to keep to themselves, and that's fine. We're not there again to push anything onto people. And you can just sit quietly near them and let them know you're ready to talk, to listen if they would like to talk. So when we want to engage with someone, we want to provide our full attention and use very calming body language, right? As we approach them and have a reassuring presence, right? Every way that you bear yourself and carry yourself and your eye contact and your voice is going to reflect a sense of safety, right? To someone who may feel unsafe. We're going to avoid initiating touch or hugs, right? we don't know if they have a trauma history, we don't know if they have a strong startle reflex, we don't know if they want to be touched, we don't know if there are cultural aspects that would make that not okay. So we're not going to run up and, oh, I'm so sorry, are you okay? We're going to grab somebody. We're not going to do that. Okay, slide. Okay, the second thing we want to do is offer a sense of safety and comfort to the person, both physically and emotionally. So how can we do that physically? First of all, what takes priority, right? We want to be sure that they have all of their medical needs met. And so even if someone doesn't have apparent injuries, we don't know, do they have a traumatic brain injury, right? So we want to be sure that everyone has the medical care that they need first. And then that they're in a physically safe place. If they're near broken glass, if there's that we're moving them away and into a physically safe area. And then we want to provide accurate information. That restores a sense of safety when people are aware of, to the best of your knowledge or whatever information you're allowed to share, that you share that accurately with the person. We're going to help survivors cope with acute grief, like Dr. Poland mentioned, which is mostly about listening and presence, calming presence. And we're going to provide reassurance. What are some ways to listen that are helpful? Some just basic listening skills include normalizing what the person's experiencing. Something like, you're not the first person to feel this way. It's understandable that you would be experiencing this right now. We can join with them. You're not alone. I'm here to listen if you need anything. We can validate how they're feeling. It's not unusual to have difficulty, right? And we can reflect. Say someone says, oh, I'm feeling so hot. Oh, you're feeling hot, right? We can reflect what they're saying. And then provide for their physical needs. Say someone just wants a charging cord or just needs water or a tissue. We can try to meet some of those basic physical needs. Some people may need some stabilization. And again, we're not talking about this in terms of trying to diagnose anyone or any disorder or any condition, because really strong feelings are a normal and natural response to trauma. So people may be expressing fear, helplessness, overwhelming feelings. What are some natural reactions to strong feelings? Well, we talk about the fight or flight response. You've heard of that before, right? So what could that look like, the fight response? Someone becoming very agitated, right? Or having strong physical reactions. Flight might look like frantic or searching behavior, or attempting to leave, maybe even against medical advice, right? Or even freezing. This is often seen. Do you all know the term dissociation? Have you heard of that? That sense of sort of where people's eyes glaze over, they're disoriented, they're numb. There's almost a sense that I'm not here right now. This isn't happening to me. Kind of like the denial that Dr. Poland mentioned was his first reaction. No, just no, this is not happening, right? So this is someone who really needs time, needs to be observed, right? May need to be stabilized. How would we do that? So our goal would be to orient someone who's disoriented in this way, okay? And we do that by using ourselves. First, we want to identify what's their main concern, if they're willing to speak to us and address that, right? Maybe that is, finding a loved one, finding a phone, finding a way to connect, finding out information, right? Or maybe a physical need. We're not going to try to convince someone to calm down, okay? Because then we're not listening and validating their experience, right? Or telling them, oh, feel safe, you're safe now, okay? That will come at their own time, at their own pace, okay? What you are experiencing is expectable. It's understandable what you're going through right now, okay? We're going to respect the patient's privacy and stay calm and quiet and present with them. And then there's something we call grounding techniques, which I'll talk about in just a minute, which is a way that was originally developed to help bring veterans back from flashbacks when they were having PTSD. But they're techniques that we can use with patients who are disoriented or dissociating. And I'll talk about that in a minute. What's our goal? To make sure they're stable. So we may just be observing until they're ready to leave the area. And we really want to release them to their loved ones. Again, like Dr. Poland said, most people want to just get back to a place where they feel belonging, safe, loved, right? And so that social support is very important. It's helpful when we're reuniting survivors with family members that we can provide some information, like a handout on coping strategies for the days ahead, where to follow up, where to find help, referrals, things like that. Okay. So what are some grounding techniques? If a patient's disoriented or dissociating or highly, highly anxious, what could we do? First of all, we need to ask for permission, right? We're not just gonna go up to somebody and say, now I want you to take deep breaths with me. You know, again, is that respectful? No, right? We want to build a sense of safety and trust and give that empowerment back to the survivor. So we could mention a couple of strategies. I think I have some techniques that might be helpful. Would you like to, have some help to feel calmer? I can help you. And let them know they can ask you to stop at any time. There are some grounding techniques that may make certain individuals more anxious. When I was working at Jackson Behavioral Health last year down in Miami, which is the big county hospital, we would often have patients where clinicians would try to do deep breathing with them. And in certain patients, deep breathing actually made them more anxious. We're trying to get them to control their breath, and then they were even more anxious about whether or not they were successfully controlling their breath. So we want to give the patient, permission to stop the intervention at any time or try something else if it's not comfortable for them. So the goal is to try to bring them back to the here and now, to where they are in the present moment. And one of the best ways to do that is by drawing their awareness to their 5 senses. Okay? So what are some basic things we can do? Can you tell me 5 things that you can see? And again, if there are many distressing visuals around them, that may not be the time to do that, okay? But, if there are non-distressing things that they can look at, tell me 5 things you can see. Tell me 5 things you can hear. Tell me 5 things you can touch. Holding an ice pack, that can bring some people back and help them calm down. Tell them where they are. This is where you are, okay? Tell them their name, things like that. Okay, so these are some strategies that are called grounding techniques to help orient someone who may be disoriented or dissociated. Okay, we want to always be very, very sensitive and mindful of cultural and religious differences, right? So first of all, we want to ask, do you have any religious or spiritual needs at this time? Well, we may not be the best person to address those needs. So if they express that they have needs, first of all, we want to consider, if I can't meet those needs, is there someone on my team who may be able to help this person, who may share the same culture, share the same religion? I've heard multiple times, say down at Jackson at a big hospital, where patients have asked for prayer. Oh, would you pray with me? Well, some clinicians feel uncomfortable with that. And if they do, they'll make every effort to try to find someone who can meet that need. Some of them do feel comfortable, and all the supervisors that I've had have said that's fine if you feel comfortable to do that, and if the request comes from the patient. What we're not going to do is say, you need prayer, come over here, right? Or engage in some other practice that belongs to the provider, right? We want that to be requested by the person. Patients may have different preferences for touch and modesty depending on culture or religion. We want to be as respectful as we can about that. And again, if there are chaplaincy resources, we would try to make those available. Some cultural or ethnic groups may not really be open to mental health treatment. They may hear, oh, you're a psychologist? Well, I'm not going to talk to you, right? They may prefer to focus on the physical or even focus on the spiritual, but not be open, and that's fine. Again, it's a choice for a patient or a survivor to talk to any mental health providers, okay? So again, I mentioned, where did this information come from? A lot of it came from Psychological First Aid, which is this free 6-hour training that anybody can do. It's at this website, the learn.nctsn.org. And they have, I think, 300 different trainings for how to intervene directly after a crisis, and then for the weeks ahead, different psychological interventions. There's the National Organization of Victims Assistance, the Red Cross, Critical Incident Stress Management, and NASP. I think that's the National Association of School Psychologists, the PREPARE program. So that's all that I have, and we would really like to open it up for your questions. See if you have any thoughts or concerns or.
Let me ask you a question. Anybody remember when you were in school and maybe sadly something happened? Maybe a teacher became ill and died, maybe a tragedy affected one of your classmates? Anybody remember something like that?